Hello everyone, I hope you're all doing okay. Welcome back from your placements block, and I hope that the placements gave you an opportunity to correlate your theoretical knowledge with different clinical case scenarios, which I'm sure you must have seen on your clinical rotations. Now, we've already kick-started with the ENT block as part of the special senses teaching. I would advise you to review the recording on the overview of the ENT system prior to listening to this lecture. That recording would be available on one of the Canvas slides on the introduction to the ENT system, I presume, on which was probably delivered on Monday. In this lecture, we will zoom into the details of the anatomy of the palate and the tongue in the neck region. Now, as part of the learning objectives, we will cover the anatomy of the palate in detail. We'll talk about how the palate is divided into hard palate and the soft palate. We'll talk about the bones forming the hard palate, and we'll talk about the muscles which are forming the soft palate, their innervation and their functions, and we'll talk in detail about the general innervation, the blood supply, and the lymphatic drainage of the palate. Then we'll jump over to the tongue, and as part of the details of the anatomy of the tongue, we'll talk about the main features, the gross morphological features of the tongue. We'll talk about the different groups of muscles in the tongue, which are basically the extrinsic and the intrinsic group of muscles. We'll talk about their actions, their functions, their innervation, and then we'll talk in detail about the general innervation, the blood supply and lymphatic drainage of the tongue. Lastly, we'll wrap up this lecture by briefly mentioning the different salivary glands in our oral cavity, and we'll talk about a little bit of neuroanatomy of the sensory pathway for the general sensation, which is the taste. Right, so as I mentioned before as well, please review this recording on the overview of the ENT anatomy prior to delving into the details of the hard palate and the tongue regions. The link for that recording can be found over here. Now here you're looking at a mid-sagittal section of the head and neck region. So let's orientate this illustration first. This is the anterior side over here, and this is the posterior side because we can see the vertebral column at the back, the vertebrae and the intervertebral discs at the back. So that's the posterior side. Here you can see a cut section taken through the nasal cavity. The nasal septum has been removed, so you're looking at the lateral wall of the nasal cavity characterized by these conchae, which are the bony shells in the lateral wall of nasal cavity. And then down below over here, this is the oral cavity, which you can see is housing the tongue inside it. The nasal cavity at the top and the oral cavity down below, these are separated from each other by the hard and the soft palate. So you can see the palate is not only forming the floor of the nasal cavity, it is also forming the roof of the oral cavity. And as you can see clearly over here, the palate is formed of a hard palate and a soft palate. The hard palate is bony, and we'll talk about the bones contributing to the hard palate in a second. The soft palate, on the other hand, as the name indicates, is formed of soft tissues, primarily the muscles, which are covered over by the mucosa. So what are the bones forming the hard palate? For that, let's take the help of this illustration over here. Here you're looking at basically looking at the roof of the oral cavity. So in other words, what I'm trying to say is that you're looking at the hard palate from underneath. The hard palate is formed of two bones, the maxilla anteriorly and the palatine bone posteriorly. The maxilla is a large bone with a body in the center, and that gives off different bony processes. For instance, you can see an alveolar process over here, which is characterized by these alveolar sockets, which are housing the teeth. And then from the inner side of that alveolar process, you can see the palatine processes popping out. These are the palatine processes of the maxilla on the right and on the left. The two palatine processes of the maxilla, they meet in the center, and they are separated from each other with the help of an intermaxillary suture. So you've got the maxilla in the front, and posteriorly we've got another bone contributing to the hard palate that is known as the palatine bone. Now the palatine bone is basically an L-shaped bone. The vertical limb of that L that contributes to the lateral wall of the nasal cavity, which obviously you can't see over here, but what you can actually see is the horizontal limb or the base of that L-shaped palatine bone. These palatine bones, the two palatine bones on either side, these are separated from each other, by a suture which is called the interpalatine suture. And then the palatine bones at the back are separated from the maxilla in the front with the help of a maxillopalatine suture. So on the whole, you can see a cruciform suture forming inside the hard palate, which is comprising of the intermaxillary suture, intrapalatine suture, and the maxillopalatine suture. The hard palate, in turn, is then covered over by different glandular tissues, which are then wrapped over by the oral mucosa. Right, so let's talk a little bit about the soft palate now. You can see the soft palate over here inside the oral cavity. The soft palate is comprising of an aponeurotic sheath, which is covered over by a mucosal lining. There are 5 different muscles which are attached to the soft palate. 2 of these muscles, they elevate the palate, and these include the levator villi palatini muscle and the tensor villi palatini muscle. The tensor palatini, or the tensor villi palatini muscle, that originates from the base of the skull, with some fibers popping off from the eustachian tube as well, and it then descends vertically downwards on the side of the pterygoid plates, and as it descends, it takes a 90-degree turn for around a bony process of the medial pterygoid plate, which is known as the hamulus. Now you can't really see the hamulus over here, but it takes a turn around the hamulus, and then it becomes horizontal in its trajectory. Here it then fans out to create an aponeurotic sheath, and that aponeurotic sheath contributes to the main body of the soft palate. The levator villi palatini muscle, that originates from the base of the skull as well. If you want to be more specific, it originates from the petrous part of the temporal bone, just medial to the carotid canal, and it then descends obliquely downwards and inserts directly onto the aponeurotic sheath of the soft palate. Remember, the aponeurotic sheath of the soft palate was formed by the tensor villi palatini muscle, and the levator villi palatini, since it is situated superior to the soft palate, you can probably imagine that the main action of this muscle would be to elevate the soft palate. The other 2 muscles are the palatoglossus muscle and the palatopharyngeus muscles. Right, so if you look at the oral cavity, you can probably see that in the lateral wall of the oral cavity, there are 2 mucosal arches. These are known as the palatoglossal arch and the palatopharyngeal arches. These are essentially the arches of the soft palate. Now, what are these arches? The arches are nothing but the muscles of the soft palate, which are covered over by the mucosa. So for instance, the palatoglossal arch in the front over here, that is actually formed by the palatoglossus muscle covered over by the oral mucosa. The palatoglossus muscle originates from the soft palate, and it is attached to the tongue, and therefore it contributes to the elevation of the posterior part of the tongue. The palatopharyngeus arch, on the other hand, which is lying posterior to the palatoglossal arch, that is formed by the palatopharyngeus muscle covered over by the oral mucosa. One more time, the palatopharyngeus muscle originates from the soft palate, and it then descends and blends with the lateral wall of the pharynx. So it basically contributes to the elevation of the pharynx as part of the swallowing process. It's one of the vertical muscles of the pharynx, and it also contributes to the depression of the soft palate as well. Now, between these 2 arches, between the palatoglossal arch in the front and palatopharyngeal arch at the back, in the lateral wall of the oropharynx, this region is known as the tonsillar fossa, and that is where the palatine tonsil or the tonsil is going to be situated. Then lastly, we've got the structure over here hanging down from the midline of the soft palate. This is known as the uvula, and the uvula contains another muscle of the soft palate, which is called as the musculus uvulae. The musculus uvulae originates from the posterior nasal spine, and here obviously you can see it's covered over by the oral mucosa as well. All these muscles of the soft palate are innervated by the 10th cranial nerve, which is the vagus nerve. But there's one exception, the tensor villi palatini, which contributes to the elevation of the soft palate along with the levator villi palatini. The tensor villi palatini, that is innervated by the 5th cranial nerve, and the 5th cranial nerve is the trigeminal nerve. The trigeminal nerve has got different branches to it, and as the name indicates, the trigeminal is going to give off three branches, V1, V2, and V3. The V3 branch of trigeminal is known as the mandibular nerve, and the mandibular nerve is going to contribute to the innervation of the tensor villi palatini muscle. Right, so now let's talk a little bit about the innervation and the vascular supply of the palate. So the general sensory innervation of the palate is via the branches of the maxillary division of the trigeminal nerve. Remember, trigeminal nerve was the fifth cranial nerve, and it was giving off three branches, V1, V2, and V3. V3 was the mandibular division of trigeminal, and we said that was innervating mainly the muscles of the soft palate. With one exception, obviously. The V2 is the maxillary division of trigeminal, and that is going to contribute to the general sensory innervation of the palate. The innervation of the palate is a little bit tricky, but we'll try to explain these nerves in detail one by one, so hopefully it'll make sense at the end of the lecture. So we have got three nerves contributing to the general sensory innervation of the palate, and these include the nasopalatine nerve, greater palatine nerve, and the lesser palatine nerve. And all three are obviously branches of the maxillary division of trigeminal nerve. Hence, you can see V2 written in front of these nerves here. The nasopalatine nerve, that actually provides sensory innervation to the anterior part of the palate, the area mainly surrounding the incisor teeth and the canine. So if you remember from your osteology practicals, if you look at the base of the skull, if you look at the hard palate from underneath, there was a little foramen present in the front over here, right on the undersurface of the hard palate. That foramen was known as the incisive foramen. So incisive foramen kind of provides a communication between the hard palate, between the oral cavity and the nasal cavity. The nasopalatine nerve is actually one of the branches of maxillary nerve which enters into the oral cavity region on the undersurface of the hard palate via the incisive foramen. So it actually enters, it is actually traveling inside the nasal cavity, and then it passes through the incisive foramen to enter into this region, and then innervates this region over here close to the incisive foramen, close to the incisor teeth and the canine teeth, and provides general sensory innervation over here to the gingival mucosa and to the hard palate and to the glands covering over the hard palate. The other two nerves include the greater palatine nerve and the lesser palatine nerve. These are both branches of the maxillary division of trigeminal as well, but in order to understand that, you'll have to understand the location of a ganglion which is associated with the maxillary nerve. That ganglion is known as the pterygopalatine ganglion. You can see this illustration over here which shows the pterygopalatine ganglion. Now, where is it situated? It is situated in a space which is known as the pterygopalatine fossa. You can see the pterygopalatine fossa from the base of the skull very clearly. This is the anterior aspect and this is the posterior aspect. The base of the skull is going to be somewhere over here, and the pterygopalatine fossa is going to be situated right underneath the base behind the maxillary bone. The pterygopalatine ganglion is attached to the maxillary nerve through two ganglionic branches. It's kind of hanging from the maxillary nerve. So you can see the maxillary nerve moving anteriorly. It's going to pass through the orbital cavity over here. And pterygopalatine fossa is kind of situated inferior to the orbital cavity but behind the maxillary bone, so kind of behind it as well. This pterygopalatine ganglion therefore is in an ideal position to take off to receive the nerve fibers from the maxillary nerve, and then those maxillary nerves, the neurons from the maxillary nerve, they can pass from the pterygopalatine ganglion and then travel through different branches which come off from the pterygopalatine ganglion and then innervate different regions of the body. So one of the branches which comes off from the pterygopalatine ganglion is called is the palatine nerve. The palatine nerve is traveling inside a bony canal inside the body of the maxilla, and as it descends down, you can see it's kind of splitting up into its two branches. These are the greater palatine nerve and the lesser palatine nerve. The greater palatine nerve and the lesser palatine nerves, these then are contributing to the sensory innervation of the palate. Now, how do they actually reach the palate? Well, if you remember from your osteology lessons one more time, you probably remember that at the base of the skull, at the base of the hard palate, there are some foramina is present right on the posterior aspect of the hard palate. Those were the greater palatine foramen and the lesser palatine foraminas. The greater palatine foramen is situated to the front, so the palatine canal basically is connected to the greater and lesser palatine foraminas. The greater palatine branch of the palatine nerve then exits the greater palatine foramen, and then it runs on the undersurface of the hard palate over here and innervates most of the gingival mucosa of the hard palate and the glands covering over the hard palate. The lesser palatine nerves, they pop out, they exit from the lesser palatine foraminas, which are more than one in number but are much smaller in size. They're present in the hard palate as well. And once they exit, once the lesser palatine nerves exit from the lesser palatine foraminas, these then run backwards and they innervate the soft palate. The blood supply to the palate is mainly from the descending palatine artery, which is a branch of the maxillary artery. And if you remember, the maxillary artery is actually one of the terminal branches of the external carotid artery. The blood supply kind of mirrors the nerve supply as well. So the descending palatine artery splits off into the greater palatine and the lesser palatine arteries. The greater palatine arteries are going to run along with the greater palatine nerve, and the lesser palatine arteries, they're going to run along with the lesser palatine nerves, providing blood supply to the soft palate tissue. The venous drainage of the palate is via the veins which are running along with the pterygoid arteries, and these are eventually destined to drain into the pterygoid plexus of veins. Now, inside the neck, as far as the lymph nodes are concerned, inside the neck and in the throat, there are quite a significant amount of lymph nodes situated in different places, which obviously overall contribute to the lymphatic drainage of the head and neck region. The lymphatic drainage of the palate, that is mainly via the deep cervical lymph nodes, which you can find situated within the carotid sheath. In addition to these lymph nodes, there are different groups of lymphoid tissue present in different regions inside the oral cavity and in the naso and the oropharynx, which are kind of important to know as well. These include the nasopharyngeal tonsil, situated right in the roof of the nasopharynx at the junction of the roof and the posterior wall. And then we've got another tonsil called the palatine tonsil or the tonsil, which is situated in the lateral wall of the oropharynx, not shown over here. But if you remember, we just recently covered the muscles which are of the soft palate, which are contributing to the two arches around the soft palate. Those were the palatoglossal and the palatopharyngeal arches, and there was a little space present, a fossa present between the two arches that was known as the tonsillar fossa, and that is exactly where the tonsil or the palatine tonsil is situated. And then there's another group of lymphoid tissue or the tonsil situated at the back of the tongue, literally on the posterior one-third of the tongue. This is known as the lingual tonsil. Together, the nasopharyngeal tonsil, the palatine tonsil, and the lingual tonsil, they form a kind of a lymphatic ring at the junction of the oral cavity and the oropharynx, literally at the beginning of the alimentary and the respiratory tracts. And this junction, this ring-like structure of lymphoid tissue created by these lymph nodes, this is known as the Waldeur's ring. This network of lymph nodes and lymphatic tissue is situated inside the Waldeur's ring at the beginning of the alimentary and the respiratory pathways. These serve as the first line of defense against various microorganisms and pathogens entering inside the body. Right, so now let's switch gears a little bit and let's talk about the tongue. Tongue is a muscle as well as an accessory digestive organ found within the oral cavity. The illustration over here basically shows you a mid-sagittal section taken through the oral cavity. You can see the roof of the oral cavity here, which is formed by the hard palate and the soft palate. The floor over here is formed by different muscles connecting the mandible with the hyoid bone, such as the anterior belly of digastric, mylohyoid, and the genohyoid muscles. The tongue seems to be resting nicely on the muscular floor of the oral cavity. The tongue has a body and a root to it, and you can see that the posterior 1/3 of the surface of the tongue, which is part of the root of the tongue, that is more vertically oriented and is contained within or is facing towards the oropharynx. The tongue has got numerous functions, including providing the sensation of taste, contributes to mastication, speech, and swallowing. Now let's talk a little bit about the gross morphological features of the tongue. The illustration over here provides a nice superior view of the tongue. You can see that the tongue can be divided into two major regions: an anterior 2/3 of the tongue, which is more or less horizontal and is situated inside the oral cavity, and the posterior 1/3 of the tongue, which is vertical and extends down all the way into the oropharynx, or faces towards the oropharynx. The anterior 2/3 is separated from the posterior 1/3 region of the tongue with the help of this V-shaped sulcus, which is called the terminal sulcus. The terminal sulcus in the center is characterized over here by a foramen, which is known as the foramen cecum. The foramen cecum is basically an embryological remnant of a duct called the thyroglossal duct, through which the thyroid gland basically descended down from the oral cavity region down into the neck region. The foramen cecum now serves as an embryological remnant of the closed thyroglossal duct. The posterior 1/3 of the tongue is covered over by lymphoid tissue, which is known as the lingual tonsil. This lingual tonsil, along with several other groups of lymphoid tissues such as the palatine tonsil and the nasopharyngeal tonsil, contributes to a ring of lymphoid tissue situated in this oral cavity oropharynx region, which is known as the Waldeyer ring. And we mentioned that it actually serves as a first line of defense against various microbes, microorganisms entering into our body. The taste sensation, the anterior 2/3 of the tongue is actually characterized by different mucosal elevations, and these are known as the papillae. There are different mucosal elevations, different papillae situated on the anterior 2/3 of the tongue. For instance, if you look over here, there are some circular elevations all along the length of the terminal sulcus anterior to it on the anterior 2/3 of the tongue. These are known as the velate papillae or the circumvallate papillae. These papillae basically increase the surface area of the mucosa and consequently increase the surface area for the taste sensation. Then we can see some vertical folds of the mucosa over here on the side of the tongue. These are known as the foliate papillae. Then we can see different mucosal elevations which kind of look like different fungiform elevations popping out from the surface of the tongue. These circular elevations over here, these are known as the fungiform papillae. And lastly, the entire remaining surface of the tongue is then carpeted by some mucosal elevations which are known as the filiform papillae. So basically we've got four different kinds of papillae or mucosal elevations on the anterior 2/3 of the tongue. These include the velate or the circumvallate papillae, the foliate papillae on the sides of the tongue, the fungiform papillae which look like different mushroom-like outgrowths, and then the rest of the tongue is covered over by the filiform papillae. The taste sensation from the posterior 1/3 of the tongue are carried by the glossopharyngeal nerve, including this little region over here, which is anterior to the terminal sulcus, where the circumvallate papillae are situated, whereas the taste sensation from the anterior 2/3 is carried by the facial nerve. So the taste sensation from the foliate papillae and from the fungiform papillae would be carried by the facial nerve. Now we're going to have a look at the tonsils. So we briefly talked about the tonsils already. There are four main tonsils in the oropharynx nasopharynx region, and these contribute to the immune system. So we've got the lingual tonsils, we've got the palatine tonsils, these are the ones which are removed in tonsillectomy. Then we've got the pharyngeal or the nasopharyngeal tonsils. Their pathological enlargement is known as the adenoid. And then we've got the tubal tonsils. The illustration over here basically shows you a mid-sagittal section taken through the nasopharynx and the oropharyngeal region. So you can see the base of the skull over here, you can see the hard palate followed by the soft palate, and then you can see the tongue over here resting on in the oral cavity. This is the horizontal part of the tongue, that's the vertical part of the tongue. Now let's identify the different tonsils over here. The lingual tonsils, let's start with the lingual tonsils. So the lingual tonsils are a group of lymphoid tissue which are situated within the submucosa. They are situated right over here on the posterior one-third of the tongue. Remember, the posterior one-third of the tongue is more vertically oriented, facing towards the oropharynx. The lingual tonsils are going to be situated right over here behind the terminal sulcus. Then we've got the soft palate over here, which is giving off two pillars, which are known as, or the arches, which are known as the palatoglossal arch and the palatopharyngeal arch. The palatoglossal arch extends from the palate all the way to the tongue, and the palatopharyngeal arch extends from the palate and merges with the lateral wall of the oropharynx. In between these two arches, there's a little space over here called the tonsillar fossa, and that's where the palatine tonsil is going to be situated. That's the one which, as I mentioned before as well, that's the one which is removed in case of tonsillectomy. Then if we go a little bit higher up over here, we're looking at the lateral wall of the nasopharynx over here, which is characterized by this opening, which is an opening for the eustachian tube. Eustachian tube, remember, that is the connection between the nasopharynx and the middle ear cavity. The tubal tonsils are going to be situated close to the eustachian tube. Then if we go further higher up over here, we can see that there's a group of lymphoid tissue present over here, which is called as the nasopharyngeal tonsil. This is literally in the roof of the nasopharynx, right underneath the base of the skull. And the pathological enlargement of this nasopharyngeal tonsil is going to be called as adenoid. In case of kids, that can lead to an upper airway obstruction, and that's why we have to do something which is known as adenoidectomy, which is the surgical removal of the pathologically enlarged nasopharyngeal tonsil, known as the adenoid. These groups of lymphoid tissue, the adenoid, the nasopharyngeal tonsil, the palatine tonsil, and the lingual tonsil together form a ring of lymphoid tissue over here, which is known as the Waldeur's ring, which we talked about already, and that serves as the first line of defense in our immune system against various microbes and pathogens entering inside the body. So now let's move on to the muscles of the tongue. In fact, the tongue is an organ which is totally made up of muscles. The muscles of the tongue can be grouped into an extrinsic category of muscles and an intrinsic category of muscles. The extrinsic group of muscles, generally speaking, they have a bony origin outside the tongue and hence contribute to the movement of the tongue or alter the position of the tongue. The intrinsic category of muscles, on the other hand, are situated totally within the muscle and they alter the shape of the tongue. For example, moving it towards one side or rolling the tongue as part of activities such as speech or swallowing. The extrinsic muscles include palatoglossus, styloglossus, hyoglossus, and genioglossus, whereas the intrinsic group of muscles include the superior and inferior longitudinal muscles, which basically, when they contract, they change the length of the tongue, they make it become shorter, and the transverse group of muscles, which when contract, they're going to decrease the extent of the tongue sideways, and vertical group of muscles, which when contract, they're going to decrease the vertical extent of the tongue. Okay, so we've got four extrinsic muscles of the tongue, and in this illustration you can see all four of them originating from different bony regions around the oral cavity and then inserting into the tongue region. So first we've got the muscle called palatoglossus. The palatoglossus muscle originates from the palatine aponeurosis and inserts into the posterolateral aspect of the tongue, which is clearly shown over here. So if you look over here, see, this is the hard palate, which is forming the roof of the oral cavity or the floor of the nasal cavity. Right behind the hard palate, this region over here, this is the soft palate, which is mainly formed by the palatine aponeurosis, covered over by the mucosa. And there are different muscles inserting or attached over here. One of the muscles which is attached to the palatine aponeurosis is the palatoglossus, and this is the muscle which was contributing to the palatoglossal arch as well, which we covered as part of the soft palate. and the palatoglossus, now you can see clearly attached over here to the palate and aponeurosis, and on the other end it's attached here to the posterolateral aspect of the tongue, since it is situated behind and above the tongue. So you can imagine that when the muscle contracts, it's going to contribute to the retraction and elevation of the tongue. If the tongue is fixed, then that could also lead to depression of the soft palate when the muscle contracts. Then the next muscle is styloglossus. This is also one of the extrinsic muscles of the tongue, so it has to have a bony origin outside the oral cavity. It originates from a bony process called the styloid process and then inserts into the posterior aspect of the tongue as well. And once again, it is situated above the tongue, comes and gets attached to the tongue from behind, so it contributes to the elevation and to the retraction of the tongue as well. Part of the action of this muscle is that it also leads to curling of the tongue when it leads to retraction of the tongue. Alright, so then we've got another muscle which is called the hyoglossus. Now here you can see the left lateral view of the hyoid bone. You can see the body of the hyoid bone continuing backwards as the greater cornu of the hyoid bone. Hyoglossus is a big flat sheet of muscle which originates from the greater cornu of the hyoid bone, and it's coming from down below, from underneath the tongue, and then it inserts into the posterolateral aspect of the tongue once again. So you can see, since it is situated below the tongue, it will lead to depression of the tongue, and it also leads to retraction of the tongue as well. Then lastly, we've got the genoglossus muscle. Now here you can see the cut section of the mandible, and if you can remember from your osteology sessions, the mandible had little bony prominences on its posterior inner aspect. These were known as the genial tubercles or the mental spines. There were two superior mental spines or genial tubercles, and there were two inferior genial tubercles. The genoglossus muscle originates from the superior genial tubercles or from the mental spines, and then inserts into the main body of the tongue over here. In fact, genoglossus contributes to the main body musculature of the tongue, and this contributes to, when the muscle contracts, it leads to the protraction of the tongue. The muscle is kind of oriented in an oblique manner. So when it contracts, when the muscle on the right contracts, it leads to the protraction of the tongue. And it causes the tongue to deviate. The muscle on the right side causes the tongue to deviate towards the left side, whereas the muscle on the left, the genoglossus on the left side, causes the tongue to deviate towards the right side. Now, since both the muscles contract at the same time, they don't cause the deviation of the tongue there. Their angular movement is basically nullified from each other, and the tongue basically is protracted in the midline. But if one of the muscle is paralyzed, let's say the muscle on the left side is paralyzed, then that would actually lead to the retraction of the tongue, the protraction of the tongue towards the left side. And that is an important information to know, especially when you're assessing the intactness of the nerve supply of the tongue, which we will cover as part of our neuroanatomy lectures during the third year. Now, this muscle also leads to depression of the tongue along with the protraction of the tongue. All the muscles of all the extrinsic muscles which we've covered, they're basically innervated by one cranial nerve, which is the hypoglossal nerve. The hypoglossal is the 12th cranial nerve. There's one exception though, the palatoglossus. The palatoglossus is innervated by the 10th cranial nerve, which is the vagus nerve. So now we're going to look at the intrinsic muscles of the tongue. So we've got the intrinsic muscles of the tongue over here. This is actually a coronal or a side-to-side section taken through the oral cavity. You can see the cut section of the tongue over here. The tongue seems to be resting over here on the floor of the oral cavity, the muscular floor of the oral cavity. You can see the cut section of the mandible on the side over here, and you can see the cut section of the hard palate, which is the roof of the oral cavity, right? So intrinsic muscles are going to be situated right over here. We've got the superior longitudinal and the inferior longitudinal muscles here. The superior longitudinal muscle curls the tongue by elevating the apex and the sides of the tongue, and it retrudes the tongue as well. Remember, the intrinsic muscles are mainly linked with changing the shape of the tongue musculature and contributing to movements such as swallowing and speech. So then we've got the inferior longitudinal muscle, which is this lower portion of the tongue musculature, just above the extrinsic muscles, which is the genoglossus one shown over here. The inferior longitudinal curls the tongue by depressing the apex, and it retrudes the tongue as well. The transverse and the vertical muscles, intrinsic muscles of the tongue, are going to be situated here in between the superior and the inferior longitudinal muscles. The transverse intrinsic muscles narrows and elongates the tongue. The vertical group of intrinsic muscles, they elevate and broaden the tongue. The good thing is that all these intrinsic muscles of the tongue are innervated by a common cranial nerve, which is the 12th cranial nerve, and that would be the hypoglossal nerve. So just to sum up, all the extrinsic and the intrinsic muscles of the tongue are innervated by the hypoglossal nerve. There's just one exception, and that one exception is the palatoglossus muscle, which is innervated by the 10th cranial nerve, and that would be the vagus nerve. Okay, so now let's talk about the innervation of the tongue. So now the tongue innervation can be divided into motor and sensory innervation. We've already covered the motor innervation of the tongue, and when we were talking about the muscles of the tongue, we said that all the muscles of the tongue are innervated by the hypoglossal nerve, which is the 12th cranial nerve. So hypoglossal nerve is the motor innervation of the intrinsic as well as the extrinsic muscles of the tongue. There's one exception though, and that exception was palatoglossus muscle. Palatoglossus is also a muscle of the soft palate, and remember, all the muscles of the soft palate are predominantly innervated by the vagus nerve. So the motor innervation is therefore coming from the hypoglossal nerve predominantly, with the exception of palatoglossus, which is innervated by the vagus nerve. Then we jump over to the sensory innervation. Right now, for the sensory innervation, we're going to divide that into a special and into a general sensory innervation. Remember, the special sensory innervation relates to the special senses, such as hearing, vision, and taste. And in this case, we're going to be talking about the taste sensation. The general sensory innervation leads to the sensory perception, relates to the sensory perception of touch, pain, temperature. So basically those sensations which can be perceived in any part of our body, and for that matter in the tongue as well, right? So we've got general and we've got special sensory innervation of the tongue. Now you also probably might remember from the previous slides in this lecture that we said that there's a V-shaped sulcus, the terminal sulcus, which kind of divides the tongue into two regions. There's an anterior 2/3 of the tongue, and then there's a posterior 1/3 of the tongue. Now the anterior 2/3 of the tongue has got its general sensory innervation coming from the mandibular division of the trigeminal nerve. So the V3, or the mandibular division of trigeminal nerve, that is going to be responsible for taking up the general sensations from the anterior 2/3 of the tongue and then conveying that information to our brain, where the information is going to be perceived. The special sensation, which is the sensory information of taste, that's going to be perceived, and that's going to be carried by the facial nerve. There's a branch of facial nerve called the chorda tympani, and that is the nerve which is going to be receiving that sensory information of taste from the tongue and then carrying it to the brain. So the anterior 2/3 of the tongue has got its general sensory innervation coming from the lingual nerve, which is a branch of the mandibular division of trigeminal, and the special sensation of taste is carried by the chorda tympani nerve, which is a branch of the facial nerve. The good thing is that the posterior 1/3 of the tongue has got its sensory, general as well as special sensory information being carried by a common nerve, which is the 9th cranial nerve, and that would be the glossopharyngeal nerve. then the real and then the root of the tongue, which is the most posterior part of the root of the tongue, which is close to the oropharynx. That little bit area of the tongue is going to be innervated by the vagus nerve from the internal laryngeal branch of the vagus nerve. So just to sum up, we've got the motor innervation of the tongue, and we've got sensory innervation of the tongue, and within the sensory innervation we've got the special sensory information of the taste being perceived, being taken from the tongue towards the brain, and we've got some general sensory information taken from the tongue to the brain as well. So the motor innervation is always through the hypoglossal nerve, with one exception, which is the palatoglossus muscle that is going to be innervated by the vagus nerve. And then in the general, and in case of the sensory innervation of the tongue, we've got the anterior two-third of the tongue, where the general sensory information is going to be perceived by the mandibular division of the trigeminal nerve, to be more specific, from the lingual branch of the mandibular division of trigeminal, whereas the special sensory information of taste is going to be carried by the chorda tympani branch of the facial nerve. In the posterior one-third of the tongue, which is the region behind the terminal sulcus, that from that region the glossopharyngeal nerve is going to do the job of carrying the general as well as that special sensory information of taste, whereas the most posterior aspect of the root of the tongue, which is very close to the oropharynx, that is the region where the internal laryngeal nerve, which is a branch of the vagus nerve, that's going to carry both the general sensory information as well as special sensory information of taste from the tongue, carrying it to the brain. Now we're going to look at the vasculature of the tongue, the arterial and venous drainage of the tongue. So the arterial supply of the tongue is ultimately coming from the external carotid artery. You can see the external carotid artery right over here in the neck region, inside the carotid sheath, right behind the tongue, right behind the oral cavity. The external carotid artery gives off different branches inside the neck. Inside the neck region, and one of those branches is the lingual artery. The lingual artery can be seen popping off from the external carotid artery here, and you can see that it is supplying the tongue through its sub branches, which include the sublingual artery over here, the dorsal lingual arteries over here, and the deep lingual artery. So the lingual artery is the main arterial supply of the tongue, and it is one of the branches of the external carotid artery. The venous drainage is ultimately into the internal jugular vein, which can be seen over here. Once again, inside the neck region, running inside the carotid sheath. There are different veins, such as the deep lingual vein, the dorsal lingual vein, and the sublingual veins, which ultimately drain either directly or indirectly through the lingual vein into the internal jugular vein. So to sum up, the arterial supply is mainly coming from lingual artery, which is a branch of the external carotid artery, whereas the venous drainage is into the internal jugular vein, directly or indirectly via the lingual vein.